Well, thank you very much. I've been enjoying the discussion that has been going on in the first part of today enormously, and I look forward to what you have to say about the two topics that I'm going to address in the next 30 minutes. I'm going to be talking broadly about, I think, a topic that hasn't received enough attention in the literature, and that's just how exactly we're to assess the benefits and harms in cluster randomized trials. I'm going to talk about two topics particularly: the applicability of clinical equipoise, a key concept in research ethics, to cluster trials. And then I'm going to speak more broadly about a systematic framework for the ethical analysis of benefits and harms in research and its applicability to cluster trials. So first, clinical equipoise. There are a number of instances in the literature where authors raise concerns that speak to the treatment of control groups in cluster randomized trials. The idea is that it may violate beneficence to deprive those in the control group of the experimental intervention. And a number of authors worry about that. Clark and Donner worry that a poor benefit-harm ratio when control group subjects receive only usual care may be problematic. Glantz raised the concern that control group subjects may, quote, be burdened disproportionately by data collection requirements without receiving the benefit of services or resources in a study. Now, it strikes me that these are very important questions, and they haven't really been adequately addressed, I think, in the cluster trials literature to date. Let me illustrate that by just pointing back to an instance that Jeremy described. This was the BedNet study in Cambodia, which, as you'll recall, randomized 34 communities to either receive insecticide-treated bed nets or no intervention. One might immediately worry about that study and sort of say, well, you know, what about the control groups? What justifies not distributing insecticide-treated bed nets to all of the communities? Because we know that insecticide-treated bed nets are widely used in malaria prevention campaigns. In fact, there's a meta-analysis that concluded that insecticide-treated nets are effective. So what, if anything, makes it acceptable not to provide bed nets to communities in the control arm of the study? So that's a practical instance of this ethical worry about the treatment of control groups in cluster randomized trials. So now I'm going to talk about how we might go about answering concerns like that. Broadly, I want to situate these concerns under the moral principle of beneficence, and it's a moral obligation not to harm needlessly, and when possible, to promote the welfare of research subjects. And in the context of research ethics, it's commonly understood to require that the welfare interests of research subjects be protected. More specifically, we do that in two broad ways. That we think that people have an interest to receive competent medical care in studies, and that further people have an interest, all people have an interest, not to be exposed to undue risk solely for the benefit of others. Right? And those are the two broad types of welfare interests that we might think ought to be protected in an effective set of research ethics guidelines. The concept of clinical equipoise gets at the first of these concerns, the interest that someone has in receiving competent medical care. And so Friedman, writing in a famous paper in the New England Journal of Medicine in 1987, said that it's an ethical prerequisite for a randomized controlled trial that at the start of the trial there must exist a state of honest professional disagreement in the community of expert practitioners as to the preferred treatment. Now, a whole literature has arisen, I think, about how to interpret Friedman's standard of clinical equipoise. There are a variety of ways of thinking about the concept that are out there in the literature, and we can certainly talk about that during the discussion period. The way that I look at the concept is that it's really a statement about the state of evidence regarding the treatment alternatives in a study. And it says basically that the evidence supporting each of the treatment alternatives is such that experts either in fact disagree or presented with the evidence they would disagree as to which ought to be preferred. I think what that standard is getting at, it's a way of operationalizing the moral requirement that therapeutic procedures in a study need to broadly be consistent with competent medical care. So I think that's what clinical equipoise is really about. So it's a very important concept in the literature on thinking about clinical trials generally, certainly standard clinical trials. But there's a problem potentially in applying clinical equipoise to the context of cluster randomized trials. And it arises from the fact that it's commonly thought that clinical equipoise is rooted in the fiduciary relationship between the physician-researcher and the patient-subject. The physician-researcher has moral duties to the patient-subject, including a so-called duty of care, and that means the physician-researcher must act and advise in the best medical interests of the patient-subject. And so clinical equipoise then, according to this view of its foundations, is really a specification of the physician-researcher's duty of care to the patient-subject. Clinical equipoise gives us a moral test for figuring out when that duty of care has been discharged appropriately. But the problem, of course, is fairly close to the surface, and that is cluster randomized trials are just so heterogeneous in terms of people that are involved in them. And very commonly in cluster randomized trials, there is no physician-researcher, patient-subject relationship. Researchers may be intervening on physicians themselves in knowledge translation studies. Cluster randomized trials may involve no patients whatsoever, right? They can be school-based studies. So in the diverse set of cases that constitute cluster randomized trials, if there is no physician researcher patient-subject relationship, then how is it that we're to think that clinical equipoise applies at all to cluster randomized trials? So in the paper that we've published on this, we provide a different way of thinking about the moral foundation of clinical equipoise, and it's not one that's meant to replace entirely the notion that physician researchers have a duty of care to patient subjects, but rather it provides a supplementary moral foundation for understanding where clinical equipoise comes from. And it's to situate clinical equipoise in part in a novel trust relationship between the state and research subjects. The idea here is that there are strong public interests that are being served by medical research, by health research broadly, and the ends that it achieves in terms of knowledge ends and gains, and also the improvement of treatment for individuals. That's an important social good, and achieving that good relies upon the voluntary participation of research subjects. That research subjects reasonably expect that the state, through promulgating research ethics guidelines and through institutions like research ethics committees, that the state actually undertakes to protect the welfare interests of those who give of themselves to participate in this larger social project of health research. And as a result of that reasonable trust expressed by research subjects, that the state acquires itself a duty of care. And that duty of care is reasonably specified by the requirement of clinical equipoise. So it's an alternate story that we can tell about where clinical equipoise might come from without having to appeal to the presence of a physician researcher in a study. And that's useful because it allows us to apply the concept then more broadly than to standard patient randomized controlled trials. It's useful, I think, because clinical equipoise provides a clear criterion for the ethical treatment of all research subjects. And it tells us that exposing research subjects to the experimental or control intervention is permissible if the evidence supporting the interventions is such that, were it widely known, experts would disagree about which was preferred. And so then, with respect to the concern about control groups, then without convincing evidence for the beneficial effects of an intervention control group, subjects are not being deprived of an intervention known to be effective. And so that's kind of the explanation that clinical equipoise would give to legitimate cases of no treatment controls. So let's come back to this example from the Cambodian BedNet study and think about at least how potentially that study might argue that clinical equipoise obtained in this case. So it's certainly the case that bed nets are widely used in malaria prevention campaigns. And it's also certainly the case that there's been a meta-analysis that's broadly demonstrated the efficacy of bed nets in malaria prevention. But the researchers in this case make an important point that most of these trials, in fact, have been carried out in Africa and Latin America and not in the setting of Cambodia. So there haven't been large-scale trials in Southeast Asia, and that there are important differences both in terms of the vector and in terms of malaria epidemiology that make us wonder about whether bed nets, in fact, would be effective in the Cambodian setting. Consider the vector. I've learned a lot about mosquitoes in the process of thinking about this. And so Anopheles dirus is the mosquito of choice in Cambodia. And it actually exhibits different biological properties than the African mosquito. And some of these are actually really relevant to the efficacy of bed nets, potentially. So here are a couple of properties that seem relevant. One is that the Cambodian mosquito actually bites earlier in the evening. So it's got a peak feeding time. Love this language. Peak feeding time of 9 o'clock in the evening, whereas the African mosquito tends to bite later, right? So that could be relevant if you're using bed nets. Obviously, bed nets are going to have reduced efficacy if people haven't gone to bed when mosquitoes are biting. The A. dirus is also both exophagic and exophilic. Another more lovely terms that I've learned. And both of those means that they tend to feed outside and they like to sit outside. So some mosquitoes sort of like to feed indoors and remain indoors. In fact, these mosquitoes like to feed and remain out of doors. And again, that's something that might have an impact on the efficacy of bed nets in preventing malaria. There are differences as well that I won't go into in terms of the malaria epidemiology as well. But I think one could make a case that there are potentially both biological as well as sociocultural differences in these communities that would allow one to reasonably say that there's insufficient evidence supporting the efficacy of bed nets in the study setting. And if that's true, right, then arguably a state of clinical equipoise exists, and it's reasonable to undertake a study comparing bed nets versus no intervention. Anyway, that's an instance of how we might operationalize that. I realize we might disagree about the particulars of this study. So the point is that just in this first part of the presentation, I've tried to explain that clinical cluster trials raise important ethical questions involving study harms and benefits, and it'd be really useful to be able to apply the notion of clinical equipoise. And I think what we've tried to do is sort of tell a different complementary story about its ethical foundations that posits a trust relationship between the state and the research subject. And if that holds, then it opens up the possibility of using clinical equipoise as an important ethical concept for cluster trials. So what I want to do now is go on to the second related topic that I'm to address this afternoon. And that's the broader question about how do we determine if the benefits outweigh the risks in cluster randomized trials in health research. So broadly, how do we undertake an analysis of the benefits and harms in cluster randomized trials? Clearly, the concept of clinical equipoise is going to be part of the answer to that. So you'll see that the clinical equipoise is going to appear in the answer that we try and give to this question. So with regard to the ethical analysis of benefits and harms broadly in cluster randomized trials, there's remarkably little said about this in the cluster trials literature. Loads on consent, loads on gatekeepers, right? Really important and interesting topics. Very little said about the analysis of benefits and harms. Clara and Donner, again, anticipating so much of this, have said too often the potential risks of participating in health education or disease prevention trials have been largely neglected, which is unfortunate. And I think it's unfortunate in a number of ways that the lack of really substantive guidance about how research ethics committees are to undertake benefit-harm analyses leads to problems. It leads to ad hocery, right? It leads to one committee making one decision about a cluster trial, another committee making another decision. Maybe even worse yet, the same committee making inconsistent decisions over time, which might reasonably undermine the confidence that researchers have in research ethics committees. And practically, this, of course, is an enormous issue for people who are trying to mount multi-center cluster randomized trials, right? And in our interviews with cluster randomized trial investigators, there were commonly comments about the problem of dealing with multiple research ethics committees. Here's one of them. The investigator says, every single place had a different ethics committee, and we got different responses from the different ethics committees. That's pragmatically, that's a major problem. So there are various ways we might try and address this. I think part of the solution to this problem is actually going to be getting a systematic and comprehensive approach that can be adopted by all ethics committees to the ethical analysis of benefits and harms. At least then, ethics committees would be asking the same questions, even if they're not necessarily always giving the same answers about benefits and harms. The approach that we've been working with is something called component analysis, which is one systematic approach to harm-benefit analysis, and stems from the recognition in biomedical research that studies are often mixed, right? They contain procedures that, some of which hold out the prospect of benefiting individual study participants, whereas others are done merely for scientific ends. So it begins with a distinction between therapeutic procedures that are administered with therapeutic warrant, that is, on the basis of evidence that makes it reasonable to believe that there may be direct benefit to research participants, as opposed to non-therapeutic procedures which are administered without therapeutic warrant and solely to answer the scientific question at hand. And the idea is that different moral rules are going to apply to these two types of procedures, right? So for therapeutic procedures, not surprisingly, the question is going to be, does a state of clinical equipoise exist, right? And so long as a state of clinical equipoise exists for therapeutic procedures, then those procedures are permissible. And we've already said a good bit about clinical equipoise. That makes sense because those procedures hold out the prospect of direct benefit to individuals. But this would be an inappropriate test. Indeed, it would be really hard to see how you would even apply this to non-therapeutic procedures, sort of interventions that are being done purely to answer the scientific question at hand. For those procedures, really, there are three different moral rules that need to be applied. First off, the risks associated with non-therapeutic procedures must be minimized. Second, the risks must be reasonable in relation to the knowledge gained. And third, when the study involves a vulnerable population, such as children or incapable adults, there's often a limit to non-therapeutic risk that's imposed. So we often say that non-therapeutic risks cannot exceed more than minimal risk is the standard in Canada, or in the United States, it's more than a minor increase above minimal risk. So how does a research ethics committee implement these tests for non-therapeutic procedures? Well, first off, it looks out for opportunities. It says, look, do we really need to do all these procedures in order to answer the scientific question, right? So one way of minimizing risks is going to be, where feasible, requiring the substitution of procedures already being performed on the subjects for diagnostic or treatment purposes, right? And the basic idea there is, if a blood draw is being done for clinical purposes and you're taking separately, doing a blood draw for research purposes, why not take those bloods at the same time? It'll be one needle stick as opposed to two. It's just a trivial example about how one might minimize risk. Regarding the second moral test, the Research Ethics Committee's determination that the risks of non-therapeutic procedures are reasonable in relation to the knowledge to be gained requires that the Ethics Committee judge the study's scientific value sufficient to justify the risks to subjects. That's a judgment call that needs to be made by a committee. And let me just say as an aside, that's one of the many important reasons, I think, why research ethics committees need to include community representatives, right? A broad judgment about a study's scientific value ought to be made not only by scientists, but also by broader representatives of the community. Because ultimately, in part, it's a determination of the broad social value of the research that's being carried out. So that's the basic idea with component analysis. Some people like pictures more than words, but the idea is that component analysis proceeds in basically 4 steps. That the first thing an ethics committee needs to do is look at a protocol, identify the procedures, and then separate them into therapeutic procedures or non-therapeutic procedures. The therapeutic procedures in the second step of this test need to pass the requirement of clinical equipoise. The third step is to examine the non-therapeutic procedures and make sure risks are minimized, that risks are reasonable in relation to the knowledge to be gained, and if there's a vulnerable population, that the risks don't exceed more than a minor increase over minimal risk. And the fourth step is to combine these 2 results. And it's only if both the therapeutic procedures and the non-therapeutic procedures fulfill these moral tests that one can responsibly conclude that a study poses an acceptable balance of benefits to harms. So it's really a series of structured questions that a research ethics committee can practically ask about any study that's put before it. So this is one of the papers we're still working on. So I'd certainly, as with all of the papers, I'd value your thoughts and input on this. There were at least 2 problems with applying this to cluster randomized trials. One was the issue of the applicability of clinical equipoise. We've addressed that. The second one is kind of a difficult one about, can we cleanly demarcate therapeutic and non-therapeutic procedures in the context of cluster randomized trials, and particularly given the heterogeneity of interventions in cluster randomized trials? And that actually seems to me to be pretty difficult. We've made some inroads into our thinking about this, but for sure, not all of it is answered. I think actually this approach to harm-benefit analysis is going to map pretty well for cluster trials in health that involve individual-level interventions. I mean, I think those are in fact going to be a lot like standard randomized controlled trials. And so I see those actually as fitting into this pretty well. Cluster-level interventions, of course, are the challenge, as they are in so many aspects of the ethics of cluster trials. I think cluster-level interventions that are really a public health intervention might sensibly be classified as therapeutic interventions if we expand our notion of benefit here to include population health benefits. And that might be a useful way of sort of including public health interventions under the rubric of therapeutic interventions. So we plan on arguing that. The real challenge, I think, has to do with complex interventions, particularly in knowledge translation studies. So if we're doing a complex intervention to try and change the behavior of health practitioners, to get them to align their practice more in accord with what the medical evidence says their practice ought to be, how do we classify that complex intervention? Is that a therapeutic intervention? Well, it certainly has educational ends, and it certainly is for the benefit of patients generally. But I have to say, I'm just not sure. I guess I'm just saying I don't know. So maybe you can help us out with that one. So how might this proceed with our example of the Cambodian study, just to sort of give a very brief illustration? Well, as I said, it's sort of a four-step process. And actually, I think in this case, it maps on pretty well, in part because the administration of bed nets can be construed as an individual level intervention. So there are a number of study procedures here. There's a distribution of insecticide-treated bed nets in intervention communities and no intervention in the control communities. There's a cross-sectional survey that's done sort of before and after the intervention that involves recording, doing a survey of 250 individuals in each of the communities randomly selected and recording their age, sex, and reported use of bed nets, all of which without identifiers. And then they're also additionally seeking a single blood sample for the usual blood smears to detect malaria. So those both give prevalence estimates for malaria in all of the communities. They also invoked a mechanism for passive surveillance of incident cases of malaria, sort of people who had symptoms of malaria. And these village malaria workers would record the age, sex, rapid malaria test result, and the treatment given, again without identifiers. So the first step is to classify these procedures. I think the insecticide-treated bed nets are clearly therapeutic procedures. They're administered on the basis of therapeutic warrant, and the benefit here to individuals is the prevention of malaria. And there are non-therapeutic procedures, namely those interventions in the cross-sectional survey and the passive surveillance, that are really about addressing the scientific question at hand, and none of those procedures hold out the reasonable prospect of direct benefit. The second step is to analyze the therapeutic procedures and ensure they pass the test of clinical equipoise. We've already talked about this, and from the previous analysis, the answer is, arguably at least, probably yes. That's probably as certain as ethicists get about things, I guess. The third step is to analyze the non-therapeutic procedures. First, have the risks been minimized? Well, I think the collection of data without identifiers clearly minimizes the risk to individuals, and the use of a blood smear is in fact the gold standard for identifying malaria. So those interventions, it seems to me, the risks have been minimized. And then the Research Ethics Committee needs to ask, are these risks reasonable in relation to the knowledge to be gained? And they're going to consider things like, well, malaria is an important health problem in Cambodia, and demonstrating that the use of bed nets in fact reduces the prevalence and incidence of malaria would have important consequences for public health in Cambodia. And on the other side, it seems like the risks associated with these non-therapeutic procedures are fairly minor. So in this case, a Research Ethics Committee might reasonably conclude that the risks are reasonable in relation to the knowledge to be gained. Step 4 is put it all together. We've said that arguably the therapeutic procedures pose acceptable risk, the non-therapeutic procedures pose acceptable risk, therefore the study has an acceptable balance of benefits and harms. So I think it's certainly the case that the absence of a systematic approach to the ethical analysis of benefits and harms in cluster trials may lead to all kinds of problems, and researchers encounter these problems in practice: ad hoc decision making and problems with dealing with multiple research ethics committees. Component analysis, I think, is applicable to many cluster randomized trials, and to the remainder we're trying to work it out. I think certainly the application to individual cluster trials is clear, and I think there's a sensible application to cluster trials in public health intervention. Knowledge translation, professional cluster trials, the applicability has yet to be determined. Okay, thanks very much.